just for the communications parts of things. I'm going to start the broadcast.
You can start whenever. I'll start whenever you're ready.
Good afternoon, everybody. Starting back at 12:30, we've got Dr. Slade here to cover oxygenation for us. If anybody has any questions for me, shoot them into the chat box or email me. You probably know how to reach me, as we are about to wrap up this year's refresher. Still a lot of content out there for some of you to do online. There's some reading assignments for many of you to do. I've been grading those and getting them sent back to those that have done them so far. So if you are not quite there yet, go ahead and get caught up. I'd like to wrap this up here pretty soon. Probably another announcement about that to make here in a little while, but we'll let Dr. Slade get moving here. So I'm going to hand the microphone over to Dr. Slade. Here you are, sir.
All right, thanks, Jeff. So this lecture, we're going to cover oxygenation. It's going to be a pretty brief lecture. We're going to go into some of the basic physiology. Then we're going to cover some modalities of oxygenation and some safety tips.
Oh, sorry. I turned that off. I was cleaning it a while ago. Here, my bad. Here, I'll just turn it back on. Now you can do what you were trying to do.
Okay.
Sorry about that.
No, you're... So, I guess the first question is you should ask yourself is why does the body need oxygen? And the answer to that is energy. All of our cells require oxygen to produce energy, just like our vehicles can't burn their fuel without oxygen. Our body can't break down glucose efficiently to produce oxygen or to produce energy without oxygen. If you can remember back to your biology days, you'll probably remember something about glucose getting broke down, taken to the mitochondria in this electron transport chain, which is where the bulk of the energy is created. And at that step there, it's essential that oxygen is there for this to occur. We need this energy to maintain homeostasis and for the cells to live. So here's just a simple diagram. As you know, we breathe with our lungs. That's where we take in oxygen. That oxygen gets transferred over to red blood cells, which gets delivered or delivers the oxygen to the different organs and tissues around our body. I just threw a picture up there of the brain. If we were to become hypoxic, the brain is one organ that is very sensitive, and we would probably notice the lack of oxygen there first. The brain requires a lot of energy, so it needs a lot of glucose, and it needs a lot of oxygen to create that energy. So here's just a few terms that we're going to cover. The first is ventilation. Ventilation is the process of moving air in and out of an enclosed space. So here we're talking about the lungs. So to ventilate the lungs, we need inspiration and we need expiration. Inspiration, we use the diaphragm to inspire air, but expiration is more of a passive process where everything relaxes and we expire the air. Perfusion is the passage of fluid through a circulatory system. So here we're talking about the vascular system. So we need to be able to perfuse the lungs with blood, and then that blood needs to be carried around to the distal tissue, and we need to perfuse the distal tissue. This third term up here, respiration, is the exchange of gas across the membrane. So we ventilate the lungs, and that's where all the oxygen's residing, but we have to really get that oxygen across the alveoli membranes and into the blood. And likewise, with carbon dioxide, that gas goes from the blood across this membrane, across the alveoli membrane, into the air that we breathe out. So now we're going to jump into hypoxic respiratory failure. And there's actually a set of criteria, when we're admitting patients into the hospital that we pick up on as to diagnose someone with hypoxic respiratory failure. One that you guys are probably more familiar with is the pulse ox. So we use the pulse ox to measure someone's oxygen level or the oxygen bound to hemoglobin. And if that were to be less than 90% on room air, that would be a criteria for hypoxic respiratory failure. Other numbers that we look at in a hospital setting would be like a blood gas. We get an ABG, and we could look at the actual partial pressure of the oxygen in a patient's blood. And then there's this what's called a PFT or a PF ratio, where again it's looking at the partial pressure of oxygen in the blood in comparison with the fraction of inspired oxygen, or the concentration of the oxygen you're breathing. So when we look at hypoxia, really what we're looking at is, how much oxygen is inside our blood compared to how much we're taking in. So you have to kind of have those two numbers, and you guys do that all the time when you show up at the hospital. You say, hey, this patient's SATs are 90%, and then you'll say, and that's on let's say 4 liters nasal cannula. So that gives us an idea, what oxygen, how well they're oxygenating their blood with what amount that we're giving them. So using the pulse oximeter, this is a great non-invasive way to measure oxygenation. But it does have its limits. A patient that has poor perfusion or from shock or low blood pressure, it's not going to be as accurate. Maybe the patient has fingernail polish on their nails and you can't get a good waveform, or they're moving around, they're hypothermic, or maybe that patient that just got out of a structural fire and inhaled a lot of smoke, they could have carbon monoxide poisoning, in which case the pulse ox would read the carbon monoxide that's bound to the hemoglobin the same way that it would read hemoglobin or read the oxygen bound. And so you can get a number of 100% and the patient could still be hypoxic. Sickle cell disease can also, you could have limitations there, as well as swelling in the extremity. So I think it's just important to realize these limitations in these certain situations. But also just keep in mind that you can look at a patient. Are they mentating well? We talked about the brain, how important that is with oxygenation. Their rate of breathing, their skin color. You can look at capillary refill. So look at other signs of hypoxia as well. So let's say we have a patient. They are hypoxic. There's a few different things that we can do to help treat these patients. Firstly, we could give them supplemental oxygen, which would increase the fraction of inspired oxygen, of course. So the air we breathe is 21% oxygen. But keep in mind, when we exhale, we're not exhaling all of that air in our lungs. So a lot of that carbon dioxide remains in our lungs, and so actually at the alveolar level, it's probably significantly less than this 21%. So there's my point is there's lots of room to go up here with supplemental oxygen. And then also what you can do is assist with ventilation. Maybe they're not ventilating their lungs. So here, you could consider, do they need a breathing treatment? Sometimes we'll throw on steroids. Now that's not going to help immediately, but over a few hours it could make a big difference. Maybe they're not ventilating because they have a pneumothorax. Maybe they need a needle thoracotomy. So assisting with ventilation, that's another way to help oxygenate them. And then last, we're going to go over a little bit of PEEP. We're increasing the positive expiratory pressure in order to recruit more alveoli. And basically what this is going to do is give us a larger surface area to exchange gases across. So here are some of your basic oxygen delivery devices. You have nasal cannula, simple oxygen mask, a non-rebreather mask, bag valve mask, and then non-invasive positive pressure ventilation. So nasal cannula, this is a low flow device, provides between 2 to 6 liters per minute, and maximum concentration here delivered is 44%. So basically I guess you can think of it as you're doubling the atmospheric oxygen. Another option here would be a simple oxygen mask. Minimum flow rate here is you're going to want to at least give them 6 liters per minute, and that's just to make sure you clear any exhaled CO2 that remains in the mask. This may be better for patients that are mouth breathers. The mask, however, may cause more anxiety. But as far as the concentration of oxygen with the simple oxygen mask, it could range anywhere from 40 to 60%. So if you put on a full 8 liters, you're almost doubling that of atmospheric oxygen. And next we have the non-rebreather mask. And like any mask, some patients are going to have some difficulty tolerating this mask. Patients may complain that flow of O2 is restricted. So just ensure that you're at least, you have 15 liters per minute going and that the oxygen is flowing. You're going to have to coach some of these patients. Let them know that, they're getting oxygen and it's flowing, and take deep breaths. This here is going to increase the concentration of oxygen from anywhere to 60 to 100%. And then the mask itself has flaps on it to minimize any dilution from the room air. Whenever I see a patient with a non-rebreather mask, it always it's kind of a red flag to me, because I know they could be anywhere from, like it's shown here, 60 to 100% oxygen is what they're requiring. And if they come in on 100%, and if they come in and they're satting 100%, that's great. But I have a hard time, until I start turning that mask down, or switch them over to a regular face mask. I have a hard time really knowing what their oxygen status is. Is this a patient that's going to be needing intubation quickly, or is this someone we're going to be titrating down on this oxygen? They're going to do fine. So it's a great way to get their sats up fast. But it's also, you're kind of at the peak as far as the supplemental oxygen. So also red flag there. So next here, our option would be a non-invasive positive pressure ventilation approach. There's a lot of different terms when it comes to this mode of ventilation. But I think it's most simple put by thinking of it in terms of inspiratory pressure and expiratory pressure. So here we have inspiratory positive airway pressure. So what is that going to do for the patient? As they're taking a breath in, we're going to supply a little bit of pressure for them. So this is going to decrease the work of breathing, and we can also supplement some oxygen with that, so it's going to improve oxygenation. But as far as the expiratory phase, we could also give them pressure when they're exhaling, and so this is really what we're trying to achieve here is PEEP, or positive end expiratory pressure. What this is, like we've talked about already, this is going to recruit alveoli, and it's going to improve gas exchange. And this is really what we're obtaining when we put someone on a CPAP. Is it's just a constant pressure, and we're trying to increase PEEP in order to improve their gas exchange. And then if you combine these two and change the levels a little bit, we get what we know is BiPAP, where it's two separate levels of pressure. Both when we're exhaling, and then a little bit more support when we're taking a breath in. And this, it really combines all that, decreases the work of breathing, it improves oxygen, and improves PEEP. And this is great for, your cardiogenic pulmonary edema patients, also COPD. So we're going to just talk little tips about BiPAP. Make sure to keep the head above 45 degrees. You want to make sure to assess the patient's tolerance by applying the mask first with your hands before you strap it to their head. Initial settings, you mentioned put them on a spontaneous mode. You're going to crank the FiO2 up to 100% and titrate down. And then good place to start as far as your EPAP is 4 to 5 centimeters per water, and then the IPAP is 10 to 15. And your target tidal volume would be, the 6 to 8 mils per kilogram. And that's ideal body weight. And then just, they made mention too that, make sure when you're increasing that pressure, if you go over 20 centimeters of water, it may lead to gastric distension. So that could kind of be difficult when you get larger patients. You're really needing to give a lot of support to. It could cause the gastric distension, which would, could lead them to vomiting, aspirating, other issues. So next we're going to cover just real quick about bag masks, or, BVM. These are great for administering rescue breaths. Can deliver nearly 100% oxygen. You're going to use it with high flow, 15 liters per minute. But, honestly, in a rescue situation, you can use this without oxygen. Don't delay the resuscitation efforts in order to use emergency oxygen. So use it, of course, the oxygen if you have it. But of course, if you're considering intubating someone, you're going to want to pre-oxygenate them. So it sure is nice to get that 100% oxygen. So if you have infants and small kids, one thing you can do is blow-by oxygen. So you can use an oxygen mask. You put the high flow on. You keep it a couple inches from the patient's face. You can wave the mask from side to side. Just allows oxygen to pass over the patient's mouth and nose to be inhaled. That works great for those infants that aren't going to tolerate a mask. So there are risks with oxygen delivery. You can have oxygen toxicity, retinopathy of prematurity. There's theoretically a COPD patient. There's something called hypoxic drive, where if you increase their oxygen too much, they're not going to have that drive to breathe. Their hypoxic drive depends on oxygen, as their CO2 is usually chronically high, and so that's theoretically an issue. But I mean, honestly, in the EMS world, you're not going to withhold emergent O2. You're going to administer it, and then they just titrate oxygen delivery to the lowest effective level. I know when you probably see patients that are sick and respiratory distress, you load them with the oxygen, which I think is appropriate. But just, as you're making your way to the hospital, if appropriate, you can titrate down. Just some off-the-wall stuff here. You can also see these oxygen humidifiers. Those nasal cannulas can really dry out the nose. Patients will complain about that. So sometimes they'll have basically just a humidifier. The oxygen passes through some water, picks up little water molecules, and decreases dryness and irritation in the nares and the upper respiratory system there. A little tip here about oxygen safety: 100% oxygen, is going to cause a fire hazard. So, especially when you're using chest pads, you're trying to defibrillate or cardiovert a patient, make sure you have a good chest to pad contact. That will eliminate any oxygen pockets between the pad and the skin, reduce the risk of any issues you're going to have with the oxygen here. They also say, move the mask at least 3 feet from the victim before shocking. And, only shock when the rescuer and the oxygen are clear. Just some tips here on oxygen storage and other stuff. Here's a pressure regulator that you're going to attach to your oxygen tank. There is up there in the top right corner, you can see a little gasket up there. Sometimes those can wear and cause these to leak. So that's one thing to be cognizant about. And then, a full tank would be your 2,000 PSI. And make sure you store these cylinders upright, secure them so they're not falling. Avoid storing different types of compressed gases in the same area. Store in a well-ventilated area in case something's leaking. And do not subject cylinders to temperatures greater than 125 degrees, prolonged exposure to direct sunlight, or exposure to other heat sources. Just remember, oxygen is combustible. 100% oxygen is highly effective and can cause other materials to catch on fire, so keep that in mind. Avoid with any alcohols, aerosol sprays, solvents, perfumes, or petroleum products. And never combine oxygen with an ignition source. And if there's not any questions, that's all I have. Thank you.
So I had one.
Yeah.
I'm starting to come across more high flow nasal cannulas. Do you know anything about those that are running 25 liters per minute or higher?
Right. Yeah. I feel like different providers think differently regarding the high flow. I've seen it used more in kids that you can't find the right mask for them to tolerate BiPAP. I feel it works well with them, but I feel like it's always going to be inferior to BiPAP if you can use it. At least that's been my experience.
Gotcha.
But those little kids that either can't tolerate the BiPAP or you can't find a mask to fit them. I think high flow is great to use. They say it does provide a little bit of PEEP. So, again, like that alveolar recruitment, it can help with that as well. But I think it's been a topic of debate for quite a little bit of time here. Yeah.
So getting a lot of thank yous.
Okay.